Thank you, Nick, and thank you, everybody, for being here. It's really an honor. As Nick was sharing, I'm going to shift now to Spanish. Is it okay? I mean, do we have more English?
Hello, 1 2 1 2 1 2. Can you hear me? Okay, so I'll move to Spanish. So for us, it's a pleasure to participate in this event because, like Nick said, this is the fourth panel discussion that session that we've held, and there'll be 5 more coming this year. And so together with Nick, we wanted to know about details in implementing integrated care, because the issue of the theoretical model has made lots of progress. Many countries have been sharing things, countries where we've looked at the integration of care, but it's in the area of implementation where we've come across more challenges. So from a technological standpoint, it's extremely interesting to participate in these events because at the end of the day, we realize that technology is not the problem. There's more and more available technology. As far as we're concerned, we are applying AI and other solutions that allow us to have multidisciplinary teams, psychologists, social workers, physicians, all working the same platform. So technology at the end of the day is not the problem. Where we have found more challenges is in the area of communication, in the area of reaching agreements or coming up with standards and to see who's going to be leading what. And so therefore, we believe that in order to be able to give this a push, to give a push to many of these initiatives together with ISIC and with Nick's support, we came to the conclusion that it'd be really interesting to work with experts, with you people, to see which challenges we find when it comes to implementing these things. I'm not referring to public policies, but the idea is to see how to make things happen. So I guess this is going to be a very pleasant discussion, like Nick said, and the idea is for this to be translated into papers that we'll be sharing, and the idea is to keep on working with you and to keep on doing follow-up with you. So thank you very much for giving me this opportunity, and I'd like to thank our colleagues from the Basque Country who are going to be telling us about many of the things that are being implemented. Thank you very much.
So thanks very much, Hector. And so to start proceedings, we're going to start with Carlos Sola. He's the Deputy Director of Healthcare of the Basque Health Service. So this is going to be more of the strategic view. So, Carlos.
Hola, ¿se oye?
Hello, can you hear me? I don't know first of all, I'd like to thank the organizers for giving us this opportunity to come here. I'd like to thank all of you for coming, and those who haven't come, well, it's too bad that we'll have missed this panel, because this panel will be the most famous panel in the conference, and this will be a success case. I know that there are people from our healthcare system who perhaps don't agree with this, but in any case, we've been asked to share some clues as to how we handle the issue of integration. And I believe that first thing, like Nick said, the important thing is to make politicians become involved, to involve them. And because we all know that for 8 or 10 years, we've tried to come up with a change in the model, and we've taken a leap towards integrated care focused on people. And this is our main mantra. WHO and Europe and other countries believe that this is a way to become organized in order to come up with solutions to the evils and the problems we have. Integration is a complex issue, as you know, because this is multifactorial. This is not just care integration, but it's also social healthcare integration with the community. So all these sociological elements are difficult to handle. So we've been asked to speak for 5 minutes and to share some ideas with you, because the important thing is to organize a debate. Well, this has been like an assault. I mean, I know that this, I had to prepare this very quickly, to present it very quickly. So I wrote down a few things in order to tell you about how we work. Well, we've tried to support, I'd like to tell you here, we've tried to support integration. Fundamentally, from department, we've tried to come up with a long-term vision to see what this entails, because it's not an overnight thing. It's something that's going to take us time and effort and to bring about this mindset changes. We've tried to align all the strategic elements, healthcare plan, strategic social healthcare system integration plan. That is a document which in the end are pages and pages, but they can be used as a reference in order to come up with more operational goals and to have reference points in order to be able to measure how things are evolving. Another subject we've tried to change, because this had been identified as one of the major barriers, and that is the issue of collaboration among levels. And the major change has to do with the creation of the OSIs, with their lights and shadows, and everything that had to do with social healthcare collaboration. There's another element which was very important, and that is to come up and to provide tools to everybody who makes up the healthcare system. So here we have healthcare pathways, technological issues like histories, and empowering patients as one main ally we must have in this journey to make patients also be responsible for their health, and also the integration of professionals. One of the most important battle horses is to make professionals change their speech, their discourse, and that's no easy thing. We've had some education tools, some consensus elements, working with management teams, because the idea is to bring about this change. Sometimes with some professional profiles, this is easier than in others. And there are also issues like ways to collaborate and to give professionals clues as to how to make modifications, and also the bottom-up innovation. And I think that an effort has been made in order to be able to assess what's been made and to have some feedback. Because the idea is to be able to guide organizations as to how to behave in this journey, and other issues like SPAC or EMAC, or I don't know, you probably all know, like a system to assess collaboration among professionals. Well, this is how I see things, and this is a summary of how we've tried to do things. And to modulate things from a central point of view. And there's another issue we really like is the interés area, which is, this is a way to accompany associations along a new sort of pathways. So a collaboration network has been set up for professionals from different areas in order to be able to share experiences, fears, wishes, and different alternatives to make progress. And I believe that this has been a very positive thing. And there's another project that stemmed from this, and that and that's it as far as I'm concerned. We're all very happy to be here. We in feminine, that is in Spanish, because there are more ladies than men. So, hi Carlos, I've got a few slides. I don't know whether there'll be somebody who can take care of this, or else I'll get up and do it myself. I'll handle those slides. First thing, I'd like to thank you for inviting us. It's a pleasure to be here with all of you. And, well, my name is Deputy Director of Innovation in Cruces. And what I'm going to do is to speak about healthcare pathways and how we've incorporated or brought in innovation this is the pathway we've been following, our journey. We started with priorities, especially in the oncological area. But perhaps the most innovating elements that we've brought on board in 2015 was the incorporation of users' experience, especially in the field of COPD. In 2016, apart from including patients in the design of our journey, we also invited artists who gave us a more empathetic approach. In 2017, we also brought some new technology developed by an international consortium that develops clinical indicators regarding patients' quality of life and the history of the disease. And this is one more component that stemmed from talking to patients. And there's also the assessment of the pathology or the diagnosis. This is something we included or we brought on board in many technologies, in prostate cancer, in breast cancer, and there were other pathways where we've kept on including users' experience and design thinking. This has allowed us to come up with our own methodology in the design or redesign of the pathway. So this year, in 2019, we're going to be focusing on pluri or multi-pathologies. Here we are including user experience and design thinking, and also the PROMs, which is what patients report on. So we're going to be including all this in the pathway. As to the ingredients, well, I coincide with many of the ones mentioned by Carlos. The focus is on the patient and relatives. We include them in the design of our pathway, of our journey, and also teams, which are multidisciplinary right from the start, and they work in team building dynamics, where we also include the patient, and also we generated that need, and also the emergence of new roles, managers, liaison nurses, and pluripathology nurses, and also tools and programs that our healthcare systems provides us with. Unique clinical history, electronic consultations or visits, and so a whole series of things. When we speak about including patients in the pathway, this is what we mean. We organize workshops with patients where we have a group of 8 to 10 patients, and here we map the process together with them. So when you start on a road, you get a map in order to see how you're going to get to wherever you want to go. So we talk to the patients and they tell us what they think or what they suffer from in each stage. Here's the pre-diagnosis, diagnosis, and the different stages that patients or conditions involve. And patients tell us how they've been feeling at each stage. And this is not a satisfaction issue. This is a design issue, because this allows us to see which interventions we need to deploy. For instance, here we have the touch points, which are the and if we see something in red, maybe I don't know, this is something we can use in order to design our route. And with professionals, we'll work with other tools like empathy tools. And what we want is professionals to be in the shoes of patients, and this makes them understand and be empathetic. So I'm not going to quote every single thing, just the last part maybe that has to do with opening up our horizon and our minds. We must be open to using these tools. We are very lucky because our directorate, integration directorate, is very much open to these new methodologies, and this is one of the keys for success. And that is all for now. Thank you. Sorry, microphone, please, yes.
Okay, so let me just get make sure I do the right one. So this is Amaya.
Yeah, I think.
See? Amaya Science. And going to take the view of community?
Yeah, community intervention.
Great. Over to you.
See if I got my slides.
Your slides are coming
Bueno,
up.
tampoco
Okay.
sean...
Maybe una pregunta. For this is to Carlos as well. So you mentioned some successes in relation to engaging patients within the care pathways. Right, just for one for each of you, is what have you felt has been the biggest challenge, maybe the last 5 years? Biggest challenge to taking forward your strategies or taking forward your care pathways in reality? You could name one or two things. Translate it.
Yeah, he's receiving translation.
For me.
As regards pathways, you mean? Okay. Challenges with, I guess he wasn't listening to the translation, but we have been translating. The idea is to make professionals become involved because patients and specific experiences like the one told to us by Ines. Well, I think that as soon as you allow them to, patients do collaborate, they do join, but changing the mindset and the speech of professionals, taking into account the multitude of different motivations they may have, or from the different specialities, or nursing, or physicians, expectations change, and there's also the power games inside of our organizations, and as I see things, power games really matter. So I think that changing this and making them understand, telling them that this is, well, for instance, participating, okay, when everybody will tell you that they do think about patients, but that's theory, because it is really difficult to realize or to know whether we're actually not thinking about our own interests without seeing the other side of the coin. which is the expectations and the feelings of patients and their experience throughout this journey, social healthcare pathway. I don't know. I think that the pathways or defining maps, or however we may want to call it, this really helps us understand this change that is needed on the part of professionals and patients.
Sí, yo comparto.
I agree. Maybe one of the major complexities has to do with culture change, and to stop working in silos. I'm not referring to primary hospital care, but in different units. And this is a change that takes time and effort. And even though we're used to speaking about patients, we don't really have the patient at the core, in the center. And when we do, it's true that professionals react very positively, and they say, well, it's true, you know, what he or she is saying is really true. Yeah, but professionals are not used to working in this fashion. And there's another complexity, and that is the issue of having our feet right on the ground. I know that theory is one thing, but practice is a different story. And I believe that one of the most difficult parts is to know which methodologies to apply and how to do things, and then to be able to assess the impact we are making, we're generating. We still don't have much feedback, or we don't know much about the impact, and that's the major challenge, I believe. I was asked to come and speak about my experience from the point of view of community intervention and how we are trying to organize it in Álava province. And I'm saying trying to because it's still not out on the market. But the true thing is that speaking about after it's not easy to say much, because the way in which we present the approach to care in Álava, we knew that this is how we had to do things. Like we said over break, actually there are no arguments against what Michael said. And after adopting this model and being lucky to live in a city that follows Mama philosophy. Well, as I saw things, well, the only thing we could do in the field in the area of Álava and Vitoria was to become one more stakeholder in generating health. So the healthcare system doesn't produce 10% of the health or well-being of populations. So there's a whole bunch of agents, stakeholders who really generate or produce 90% of health. So we may push these movements forward. Perhaps we'll look for connections or work in an intersectoral way, but I don't see that the healthcare system is the leader in this sense in the community, because our experience so far has been, well, don't take care of this, don't worry about generating health in the community, because we, the healthcare authorities, will do so. When actually after a few years we see that the healthcare authorities cannot succeed or do it. So we changed the way of doing things, and basically what we do regarding community intervention is the following. Based on the needs of the community, the idea is to detect, the idea is to identify and come up with an assets map, and to see what it is that the community can generate, and to actually detect what the community is already generating, and from then on to set up networks of care, and that is, and to retrieve, to recover the spirit of our community. I think I don't think we should. So we can try and do things, but making sure that it will the community who will that will take this forward, and they're starting from the needs, the assets, and the networks of mutual support. The idea is to do things. So far, we've been identifying work lines based on needs and resources, where we see it's worthwhile to start working to set up task forces and let the rest of the primary care units that have them benefit directly or indirectly from the know-how and the dynamics that are generated, but not pretending or trying that each network have their own health network for women, for children, etc., etc. That was too much. So what we decided to do was to identify lines and by means of task forces to get in touch with communities and let communities lead those movements, and to let this be disseminated so that citizens will have access to these resources. As regards the question by Nick, if I think about challenges or difficulties that we are coming across, basically, for me, and along the lines of what Inez was saying, we need a culture change, and there's got to be a macro culture change in the macro, meso, and macro, meso, and macro. We have to go from the individual to the collective. We and user, we need to go from medical to the integral, comprehensive perspective. We need to go from reactive to proactive. With community intervention, we are in the field of being proactive, and our officers are full of reactive, and there's no more space for anything else. And if we keep on working along the same lines, there won't be any space for a reactive part. So I don't know if we can ask more from primary healthcare teams, but this is the way we need to go. And the interpreter would like to say that this lady is speaking at a supersonic speed, and it is being extremely difficult to follow her, even though I'm doing my best. We have a society that expects the healthcare system to deliver and give them everything and solve everything, and they come to our office waiting for us to give them a tablet and that will solve all their problems, but they don't want to hear about eating less sugar or doing exercise. So we need to know how to give the situation a twist, turn, and improve things with the resources we have. So we need to change our mindset, or else I don't think that our system will be sustainable in the future. And our apologies. My apologies. Microphone, please, Nick. This is the interpreter. Thank you very much.
Just a plea from the interpreter to maybe go a little bit slower for the English translation would be really helpful. But that was really interesting. Thank you. Right. I'll come back with a question.
Bueno, que te presentes.
My name is Aranzazu Gonzalo. I'm a director of integration in Basurto, and I've been asked to speak about situation experienced in the social healthcare system by our organization. As you may imagine, where the integrated healthcare system has been a difficult area to organize, so let alone the social area. Once the integrated social healthcare system was organized, we found that this was very difficult to coordinate with social services. We are living more years, but are we living more years with a good quality of life, or are we coming across problems of dependence and disability? Can we really face that challenge? And also social demographic changes in the last few decades show a dynamic society in a constant evolution and change. The municipality of Bilbao, we have a very serious aging problem. Over 30% of our population is 60, 70 years or over that. And also habits have changed towards new ways of doing things, consolidating the welfare state with the different benefits. And with everything that I've told you, the true thing is that the line that divides healthcare and social needs is becoming more blurry, and we need a sequential treatment. But there's the complexity of our institutional structure. In the healthcare area, this complexity has been diminished by the integrated structures. But we find that in the social area, the interinstitutional dependence goes from provincial government to town council to government. It is true that all this is presenting an important challenge, and we need to overcome those difficulties that we are encountering. In Basurto, we thought of a first contact with the town council to see where we should start working as a municipality. So we agreed that we need to come up with a social healthcare committee, and we tried to include different stakeholders, town council with its different departments, the mental health care system, and the long stay hospital department, and Bilbao Basurto. And at the same time, we thought that it'd be interesting to carry out a social health care diagnosis of Bilbao. And we came up with an important challenge. It meant a huge effort, but we thought we could have a static image of a given moment. So we we divided Bilbao into 7 sectors. You must think that population amounts to 376,000 inhabitants. We've got a prison, 25 units for primary health care, and we've divided our units into those 7 districts, and we came up with a picture, especially focusing on those diseases, those pathologies that created more disability and dependence, social problems, housing, pregnancy, gender violence, etc. So thanks to this, we gathered enough information in order to start with our projects. This social healthcare committee was organized into different groups because we wanted to act on a target population, and we relied not just on institutions who were participating in that commission, but on all those institutions we thought that could help us or that could be necessary. And we started seeing this in the different pathways. That's it without forgetting the participation of the citizens, of patients, right from the beginning, from the start. For instance, in palliative care, which is one of the areas that we focused on. So we had a protocol, healthcare protocol, and we thought that we were lacking something. So a series of institutions got together in order to see where we could improve, the life standard of a person, that is, to taking care of that person. So we asked Cancer Association to participate with us, And a person joined our group. This person gave us a vision, a very different vision of what we normally see as healthcare professionals. We try to rely on all institutions and on all the resources we have in order to try and make life easier and to facilitate the life of that person, not just health status of that person, because I believe we do things well from that point of view, but other areas like these people feeling lonely, fears, living decently, resources, and these things were worked on thanks to that protocol. Many different protocols were created. We focused on childhood, and we thought that was a great opportunity to work with children, with vulnerable children, because of problems in their families. We detected 3 action areas in Spain, in Bilbao, Recalde, 3 different areas in the city. We started with a pilot project in the area of Recalde, and it's I must say that the satisfaction by families and professionals was extremely important. It wasn't just the root social groups working, but there's also the participation of society, some foundations, the education department, an extremely important area or sector that we normally forget. Which is where our kids spent most of our time, and we also focused on other areas like homes. We started working with OSAKIDETZA home, which is a social healthcare home. So we broadened our scope of action in the Provincial Council, the mental health care network in Biscay, etc. And what problem did we encounter? And that was a clinical history. We had different clinical histories. So together with OSAKIDETZA, we started acting as if they were our own healthcare center by facilitating all their communication, referrals, home care. And the true thing is that it was a wonderful experience, which we thought we had to broaden. Bilbao, as you may imagine, has a large percentage of its population in homes, over 5,000 people in homes, 42 homes, more or less, that were share their clinical history with us. We've started coming up with programs, coordination programs with them, because thus we have a collaboration in the area of referrals, and we are empowering them in the field of communication. I don't know. There are many more projects, but and I've tried to give you a few brushstrokes regarding lights and shadows. But and of course, we do have problems. We do have difficulties, but there are ways to overcome, to bypass these difficulties. And as our tools evolve, the situation also evolves for the better. Thank you very much for your attention.
Thank you, all four of you. Have a think in the audience if you'd like to ask some questions or clarifications, but we're looking at implementation challenges and successes. I'm looking at Hector. I think we'd like to ask, one of the things that didn't come up from the four presentations was the role and importance of data and information. That's one of the things I might want to ask, and Hector, you might want to fashion a question on that, but maybe I can take maybe one or two other questions from the floor and we can field them as a group of questions. Might be the best way to do it. You can shout them out if you like. Don't be shy. Anyone? Yes. You shout and I will repeat the question from here.
So for a lot of organizations, patients are really scary to work with. So on the roadmap, you talked about design thinking involving each.
Yes, but nobody else in Spanish will know what the question was. Okay.
So you're saying patients are really scary to work with, and on the design roadmap, you're talking about 8 to 10
Patients participating in the workshop.
patients participating in the workshop.
How did you identify them?
Okay. So how do you identify the patients who take part in the workshop? How do you make that representative, and how do you get them engaged? Because I had a question on citizen participation as well, because I think it's really important, but it's making, how do we make that inclusive?
Sí. Bueno, cuando identificamos
When patients are identified by professionals in their office, we talk to the professionals team and we tell them about the archetypes. Because we don't want to know about satisfaction. We want to know about types of patients. That is, the idea is to have all patients' archetypes represented, because this helps you identify where you may have minds or problems, because the idea is not to look for representativeness. We want to know where there are critical elements and how we can do something about these critical elements, maybe to do an intervention or not, or when to give education, when to give education, when to provide education or information. I'd also like to say that when we do the map, we identify positive, negative, neutral sort of experiences. And some of the things that are identified by patients, even though you may have positive things, they also come up with areas for improvement. Even though everything may seem fine, we also come up with areas to improve. Okay, I'd like to answer this question. We don't refer much to technology. We have quite a good, sophisticated clinical history tool. And there's also business engineering or business intelligence or data mining. We've been in touch with Watson and other elements in order to try and implement tools that will allow for much better connections to facilitate interactions between patients, professionals, and among professionals. But alternatives are not too clear. I belong to a task force in the government that's trying to set up big data experiences, and many companies that give us millions of or have millions of data, but then the problem is how to navigate around all these data. So we need to know how to have information that's relevant, use of one same tool by different elderly homes, and this gives us the opportunity to draw information and to get information in order to be able to make decisions. And other technologies that are under development, we have experience, an experience like the patient's comprehensive history. This allows us to design intervention programs together with different agents and to be able to allow for communication to flow from one professional to another. And We hope to keep on making progress along these lines. We've also had meetings with IBM, who've told us about virtual visits. This opens the doors to many possibilities.
Okay. I had a question. Yes, thank you. It's for you around your integrated health organization, 7 districts. What's the geography? What's about the size of the districts? Are they natural communities, neighborhoods?
Comunidades naturales como tal.
Natural communities as such. Well, actually, I'm referring to areas where we have social areas that are split into areas where there may be districts of 30,000 inhabitants or less, but normally these are areas that present a specific social complexity. So when we started doing the diagnosis of the different districts, we thought that in some of these districts there were clear differences, and we thought it'd be interesting to do a diagnosis according to boroughs, to areas, because one same district could have 2 completely different social circumstances.
So this is interesting for me because we're involved, EFIC is involved in a project with the network of European foundations. And it's looking at integrated community care. So building on your point about how we use all of our community assets in a way to resolve health and well-being issues. And when you look into the projects that seem to be most effective, they focus upon this kind of place-based approach. And I know we've talked about it, it's come up a few times during the conference around how we need to be able to think strategically and big at a political level, but actually the interventions are local. And they're about people and relationships and about communities with real needs and building your integrated care system with, rather than around the communities, you build it with the communities. And this is what I'm hearing from you. So I've got corroborating evidence from this other group. There's a really interesting project, for example, in Cumbria in the UK. So this is the Lake District, a beautiful part of the world. And they have created across a population of something like 700,000 people, about 20 or so of these community care districts, which are very much led and owned by the communities working alongside the health and social care authorities. And by taking an assets-based approach, they've really turned around a system that had significant public health failures to one that is getting a lot better. And it's the community-driven approach which seems to be a key to that. So this is interesting. You have similar ideas emerging. We have time for at least a couple more questions or comments from the floor. And I think there's a lady here. Yes, there's a hand up here. I think is that Coldo? Can't see you with the light. It's Coldo. So we have a question.
Thank you, Nick.
And thank you all for your presentations. I would say that you've mentioned there's so much needed change in professional culture and organizational culture. Carlos also mentioned what are the differences in the powers of organizations and all interested involved or vested. But can you go deeper and discuss to what extent you think you as health organizations, you can cause that change? How can you lead that change?
Muy gracioso, Goldo.
Funny, Goldo. All right, so I would say We don't know how, but still keep on trying. Classical methodology for the change is just the same, I would say. It's all about trying to sell values, different values. And so it is an element that we are now getting back from the corporate basis, working on values, or the essence that it's been discussed here. What Ines, sorry, I forgot your name, what Ines said. What to see and how to see the patient expectations. Also the values of people-centered care. People matter, and we have feelings, even healthcare professionals, we have feelings. We professionals have our pains, our problems, our complicated situations. And so that's what we're trying now, as a future journey. In other two hospitals, they also work very much on values, and I think that's what's new, that comes to mind, top of mind. That's what I would think of. Those of you working on cultural change, you are the experts here. It's time-consuming, it's slow, and there are many buttons to push. Yes, I would add this idea of trial and error and prototyping. It cannot be all perfect from scratch, and I guess the proof of concept for organizational changes do work. And I would say it's a key, or if not, this is one of the ways we're following. Payment or incentive change models, have we done them? Well, we have other incentives, but everyone gets paid every month. So contrary to other organizations, we don't have those performance bonuses or anything like that. As I was managing a hospital, a surgeon approached me and said, since you have that performance payment, you do great. And I look at him like, what do you mean? How do you get that your money? Because I don't get that performance pay. It's not been a model that in the Basque country for the health department we've ever used. There was an attempt with a contract program and some organizations as a clinical management, but no, that was not explored.
Okay. Well, I'm going to take one last question from Walter, I think.
Thank you very much. Very interesting conversation. In the interest of time, I have a question that's got two parts, so maybe one person could answer one part and the other the other. And it both deal with data and measurement. I saw that you had many places that you talked about measurement. You talked about patient-reported experience measures. I saw the ICHOM logo. I'm interested in two uses of that data. One for monitoring your improvements or any quality improvement, we might call that audit feedback, of using that data to share back with the teams. And the second part is the use of the data for evaluation of more, have we achieved what we wanted to?
Okay.
De lo que he intervenido, sí que hacemos lo que quería decir al principio.
What I meant is that when we look about the progress of integration, we have those references. The program contract that has, I don't know, over 200 indicators, which is a hybrid between FQM and triple meta. I don't know if you've heard about that. It's patient experience, cost, and well, a series of intermediate indicators on quality and security and everything else. So it is a mixture of systems for deployment results, following some scores and see how much progress is being done. It has to do with a generic model. Apart from that, in some of the panels here, if I'm not mistaken, there will be an ad hoc study on the, well, it's from last year with intermediate indicators and something a bit more in-depth about the progress of integration that, as Aranza said, there are highlights and there are lowlights or shades. And then I guess Inés can explain her experiences and see how we can do and what we do. And what about specific journey indicators and diagnostic types and things that we can, well, it can take us to a different future, which is closer and closer about health outcomes and results, which I would say is what we need most or what we want for our focus in the future.
Sí, bueno, además de, efectivamente,
yeah,
la evaluación en términos casi de proceso, ¿no? De tiempo.
If we talk about times and assets and processes, that's the way we're looking at it. With the new model introduction, as he says, where we're actually including quality of life and the condition of the patient, that's where you're looking into impact. Right now, we have an assessment that is a 2-year cutoff for ictus and prostate cancer. We can see clinical results and patient-reported results, and we're also seeing costs as well. The idea is that this assessment will be done by the process multidisciplinary team. As for the journeys we are starting now, what we'll do is include the PRO. So the care journey will give us not just the flow and the results and what it gets us as the process, but we will also include what has to do with quality of life perception. I want to get deeper into that because I think it's important, since these data are registered in the record, the patient's record, and it's been arranged like that. It is a reality. You have it on the record, and you can go to the folder and reply. And this is just another piece of information for the lab. And this is the quality of life survey that we register. And so we can talk now about health impact.
I'm afraid time is leading us to a conclusion, so we need to give way to the next session. But on behalf of EFIC and also IBM Watson Health and Hector, we'd like to thank the 4 panelists for sharing their thoughts and experiences. It's been a really rich session, so thank you very much to everyone. Many of you will need to move around the building. Just to remind you that there is a session L, which isn't in your program, but is on the app, which is looking at experiences in palliative care. That's in the Zuriola room. So if you get the opportunity to have a look at what it feels like to be a palliative care patient, you fancy to look at that experience, then that's in the Zuriola room, and it happens 3 times over the next hour and a half. So with that, we hand over to the next session. So thank you very much.